Dr. Savant is a medical oncologist and breast specialist with Diablo Valley Oncology and Hematology.
Thank you very much. You guys hear me? I don't think my teeth are really that white. I wish they were. So thanks for all of you guys for coming out this morning. And this is our third year doing this program, and we love to do this program. We're so excited to be here. On behalf of Diablo Valley Oncology, I'd like to thank the American Cancer Society and the cancer support community and AstraZeneca for making this program possible so that we could bring this to our community here in the East Bay. I would like to also repeat the thanks to Sandy Goldberg from Diablo Valley Oncology, but I'd like to extend that to Shana Sullivan, who worked very, very hard. So thanks for bringing this together. And then all of the other volunteers from Diablo Valley Oncology in the very fancy pink scarves, boas. Thanks, you guys. So I'm actually very curious to get a show of hands as to who has been to this program in the last 2 years. Okay, good. About maybe a quarter of you guys are repeat. So thanks for coming back. We always get really nice feedback, and so it's nice to be able to do this again. So when we talk about breast cancer, you hear the statistics that this is the most common cancer in women. More than 200,000 women are diagnosed in the United States every year, and that number continues to go up every year. So it used to be about 1 in 8 women got breast cancer. The latest statistic is 1 in 7 women will get breast cancer in their lifetime. So the number is going up. We also know it's the second most common cause of cancer death in women, second to lung cancer. But what I really like to focus on is the fact that despite these rising numbers of breast cancer diagnoses, the number of survivors continues to go up. So the mortality rate, death rate, is going down every year. And what that means is we now have, as Heather said, more than 2.5 million breast cancer survivors in this country right now, which is astounding, and that number goes up. And you guys are part of that number, so congratulations. I'd like to, let's see if I can do my slide here. There we go. What is a cancer survivor? So my patients will ask me, am I a survivor yet? Where am I in my journey? So this is one of the many definitions for a cancer survivor. This comes from the National Cancer Institute. An individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. Family members, friends, and caregivers are also impacted by the survivorship experience and are therefore included in this definition. So that means that every single one of you sitting out here is a survivor, including your loved ones, friends, and family members. We're here today to celebrate all of you and to honor you and to be able to discuss the unique issues that come along with being a breast cancer survivor. And as an oncologist and part of the oncology team, we used to just have to know how to treat cancer and how to give chemotherapy and how to give radiation and how to do the surgeries. But now, because the survivor pool is so huge, such a large part of what we do is dealing with the issues that come after the acute cancer care. And so sometimes in my day at work, I feel like I'm also a cardiologist and an endocrinologist and a primary care doctor and a gynecologist and a psychiatrist, because all of the issues that come up after cancer care involve your whole body and your whole quality of life. And so that's what we're going to be talking about today. So this is a quote I came across from the Leukemia and Lymphoma Society. It's not just that you live, it's how you live. So of course it's important to survive your cancer, but if you come out on the other end with a very poor quality of life, that's not our goal. So what we really are trying to focus on, and when I say we, I mean all of us, but I mean the whole country is really moving towards focusing on cancer survivorship and not just letting people finish their cancer treatment and then say, bye-bye, you're done, we helped you and it's over, because it's not. And so obviously the issues that come with side effects of treatment, monitoring for recurrences, continue to go on for decades. So today, and some of you have been to the program before, know how this is organized. The speakers have relatively brief talks because we can't cover too much, all of us, in this short time. And what we really want to do is have it be somewhat casual so that we can have a lot of discussion and questions in the second half of the program. So we're going to do a lot of overview when we're up at the podium and then be able to get deeper into some of these issues during the question and answer session. So I'm going to just talk about a general overview. When we think about survivorship issues, there are a few different aspects of it that we're going to be talking about. So healthy lifestyle is going to be addressed by Michelle and Betsy, and I'll let them talk to you guys about that. And I'm going to talk somewhat about the long-term side effects of treatment, just touch on them, and again, we'll go into them a little more deeply. And then surveillance for cancer recurrence is a big part of what being a survivor is and why you continue to see your oncologist and your healthcare team after you've finished your diagnosis and treatment. So this is a very long list, which only begins to cover some of the side effects that you guys experience after you finish what I like to think of as the acute phase of your care. So many people, when they're diagnosed with breast cancer, go through surgery. Many go through chemotherapy, not all. Many go through radiation, and then many are on hormonal or anti-estrogen treatments, as well as some other treatments, of course, that fall into there. So we could spend 2 days probably talking about these issues, but I have 15 minutes. So lymphedema and arm mobility problems, I think many of you are aware of. Luckily, a lot of these issues are much less common because we've come so far in our local treatments. So the sentinel lymph node biopsies, which are now done for breast cancer diagnosis, mean that the surgeons only have to take out a couple of lymph nodes as opposed to doing a full axillary dissection as we used to do, taking out 10 to 20 lymph nodes. So the risk of lymphedema is much lower than it used to be in the past, but it's still there. And aside from that, women do still often need radiation after their surgery, which can contribute to that risk. And there can be, without lymphedema, just mobility issues, tightness in the chest wall, and pain. And those are things that women live with. And referrals to people like Betsy and other physical therapists are very important for you to be able to obtain from your oncology team. So many women finish their cancer treatment and wonder why they don't have 100% of their energy back the next day. And I'm constantly reminding my patients that it will take a year after you finish chemotherapy to feel like you're back. And one of my patients the other day, she finished 5 months of chemotherapy, underwent bilateral mastectomies, came in to see me and about to start her radiation. She said, my husband said to me, Mom's back. He said to the kids, Mom's back, she's 100%, she's back on the horse again. And she looked at him like, are you crazy? This is just the beginning of what I have to deal with. So it really takes a long time, and I think women expect a lot from themselves. That's what we do, right? We're moms, and we work, and we're busy, and you expect yourself to be at 100%, and you have to really learn that it's going to take time, and you have to be patient with your body. And so fatigue issues are things that aren't talked about very much, but take a while to come back, and may not ever come back to 100%. Pain is multifaceted. There's many reasons to have pain after cancer treatment. People who are living with cancer, which I think today is a relatively small population, meaning that people who have active cancer can have pain from cancer in the bones, for instance. But people who've gone through their cancer treatment may have pain, again, in chest wall or arms from their surgery and radiation, or they may have pain from neuropathy, which I didn't put on the list, but the numbness and tingling that can happen from some of the chemotherapies. And then we have the aromatase inhibitors, which are the estrogen blockers in postmenopausal women that many women are on, and those medicines can really cause pain. And so pain is something that many women have to learn to live with, and we try to help you get through it, minimize that as much as possible. Weight gain is a constant complaint among women who've gone through breast cancer treatment. Sometimes it's from just changing their level of activity, and Michelle's going to talk a little bit about this. Chemotherapy itself usually makes women gain weight, which people don't like to hear that up front. And then, of course, menopausal things. So many times we're putting women into early menopause, or if they're already in menopause, we're worsening their menopausal symptoms with their estrogen blockers. All of those things lead to weight gain. And it becomes very frustrating for women because we tell them you have to be in shape, you got to exercise, you have to eat well, and the closer you are to your ideal body weight, the lower your chance of recurrence is. But at the same time, we're giving them treatments that make them gain weight. And so it's a very difficult situation to be in. And again, I'll leave some of that to Michelle to talk about. Depression and anxiety. And we actually were talking up here at the panel that it might be nice to have a psychotherapist as one of our panelists next year, because I think the psychological issues that go with a cancer diagnosis are huge. And I can't even begin to touch on the many reasons why women develop anxiety and depression because of breast cancer diagnosis. Of course, there is the worry once you've gone through treatment that the cancer is going to come back. And that anxiety is always there. I think it gets a little bit less the further away you are from your diagnosis, but it never goes away. A lot of women, after going through breast cancer treatments, have changes in their personal relationships. Sometimes there are divorces, changes with relationships with parents or children. And I have to say I've had a number of women lose their jobs going through their cancer treatment, and that can be a very, very difficult thing to go through. Insomnia, chemo brain, these all are things that women experience every single day. Chemo brain is something that's real, and for a while I think the oncology community, before I got here, said it didn't exist. But we know it exists, and we don't unfortunately have a lot to do for it, but it is a real phenomenon, and it's, I think, reassuring for women to know that yes, there are some effects on my memory and my thought processes from my treatments. A whole nother topic in itself is menopause and infertility and premature menopause when we treat young women with breast cancer. Last year we had a wonderful speaker, Sandy Altman, come and talk about how to treat hot flashes and vaginal dryness and lack of libido, and that's a whole talk in itself, and some of the recommendations that women get from their gynecologists are controversial from an oncologic standpoint, so talking about whether or not it's safe to use local estrogens and things like that. I'm not going to talk about that too much up here, but we can get back into that in the second half of the program. The couple of issues that are more sort of medical and have kind of longer-term medical issues are bone health and cardiovascular health. And as oncologists who treat breast cancer, we become experts in osteoporosis and osteopenia, because bone loss is such a big part of what happens to a woman after they go through breast cancer treatment. And sometimes it's from a young woman being put through chemotherapy and being put into early menopause. Sometimes it's just worsening of menopause itself. And then the aromatase inhibitors, again, which we use in about 75% of our patients, can cause bone loss. So we have all learned how to interpret bone density tests and how to be very up to date on all the bone drugs that are out there. And last year I talked a bit about the bisphosphonates, which we have Fosamax and Actonel Boniva are the oral bisphosphonates, and then Zometa and Iridia are intravenous. And those have had some exciting data over the past few years that they may actually help to decrease the risk of breast cancer. The studies are not quite fully mature in that there has been some controversy with some of the more recent studies showing that that may not be the case as much as we thought. And then a lot of you know from just the news, Fosamax is starting, in that class of drugs, starting to get some difficult press with these femur fractures. And there were some studies that showed that women who are on bisphosphonates for osteopenia or osteoporosis for more than 5 years may have an actual increased risk of fracturing their femur, their thigh bone. I actually reviewed some of that data recently, and there were some recent studies that showed that it's a very, very small risk. And one of the studies I most recently looked at from the New England Journal of Medicine showed it was a 0.3% risk. So it's a very, very tiny risk, and I think sometimes those very small risks get blown out of proportion. And we know that these drugs are still so incredibly helpful to treat bone loss in the general population and also in women with breast cancer. I believe since our last program, or maybe right around the last program, a drug called denosumab was approved. This is also called Xgeva or Prolia, and this is a new drug and a new pathway for treating osteoporosis, osteopenia, as well as breast cancer that has spread to the bone. And so these are exciting drugs. We're all just starting to learn how to use them because they were just approved this year, but it gives us another option for treatment for bone loss. And I think we sometimes minimize cardiovascular health. And when we talk about all the breast cancer statistics and it being the number two cause of cancer death in women, all of this is still secondary to heart disease, right? And so heart disease is still the number one cause of death in this country for men and women. And so it's very, very important for breast cancer survivors and everybody to continue to see their primary care physicians, who are really the ones who help to monitor for cardiac risk. But a lot of what we do during our treatments for breast cancer can affect the heart. And about 25% of breast cancers have a protein called HER2. And those of you who have it know what I'm talking about. It's a specific protein on the breast cancer cell for which we give a drug called Herceptin. And Herceptin is a fantastic drug that improves survival by 50%, but it has a low risk of affecting the heart. So that's one of the drugs that when people are on this drug for a year, they have to have their heart monitored every 3 months. And it just raises our little awareness that we need to keep an eye on this person's heart. That's usually just during the time of treatment if it's going to happen. And one of the chemotherapies we use a lot for breast cancer is adriamycin. And adriamycin also has a risk of damaging the heart. And this is a risk that may not present at the time of treatment, may come along in the next few years. So the heart is still very, very important, and you can survive your breast cancer, but we don't want to hurt your heart. So we keep an eye on that, and there are more and more studies looking at possibly eliminating adriamycin in some patients with breast cancer, but we're not quite there yet. There was some concern when the aromatase inhibitors came out, that's one of the estrogen blocker categories that we use for postmenopausal women, that they may actually increase heart disease. I was at a recent update in September, which showed that that doesn't seem to be the case. And so this is good news. And what the analysis have showed is that compared to tamoxifen, these drugs are not as protective for the heart. So tamoxifen is actually a drug many women take, which actually is good for your heart. The aromatase inhibitors are about the same as just not taking tamoxifen. So that's actually pretty new data that the oncologists are excited about, because there was some concern initially that we might be affecting heart health with the aromatase inhibitors. And then one other thing, which is a little bit less common, but I bring it up because our survivor may touch on this, is that there can be some damage to the lungs during treatment, particularly during radiation treatment. And that's not very common, but it is something that several of you or some of you in the audience may have experienced. And I don't know if Heidi's including that in her journey or not, but that is something that can sometimes come up and need to be dealt with. So that was just a real quick run through. Obviously, there's so much more to talk about there. But when I see my patients in follow-up, so women who are not in active chemotherapy treatment, and I'm seeing them as sort of their 3-6 month follow-up, maybe yearly follow-up, a big portion of our visit is talking about these kinds of issues and side effects that are going along with either the hormonal treatment they're on now or side effects from treatment they received in the past. And then a big part of our visit is to just talk about whether we're concerned if the cancer is coming back. And some women have stage 0 DCIS, non-invasive breast cancer, and some women have stage 3 breast cancer. And as oncologists, we know that the risk of recurrence is different between those two women, but you as the patient feels that anxiety at the same level. And so that's something that I always am very careful to be sensitive to, is that women are concerned about their recurrence. And while we may be sitting in our chair saying, oh, that pain that you have is not worrisome and that's just this or that, you really have to, me as the caretaker, to be sensitive to the fact that that's probably your number one worry when you come in with a complaint is the cancer back? And so cancer surveillance is very, very important part of what we're doing when we continue to see you every 3-6 months and once a year when you get a little bit further out. And we don't do routine scans, and I've talked about this in the last couple of years. Some women ask me, why don't I get a CAT scan or a PET scan once a year or every 6 months to find out that my cancer hasn't come back or has come back? And this has actually been studied scientifically that it does not improve survival to do routine screening scans. And that is because once breast cancer has come back in another organ, it's not curable and it's not going to go away completely. We can treat it, we can maybe get it into remission, but finding it a few months before it causes a symptom does actually not change the outcomes. But what does happen is you expose a lot of women to radiation and to anxiety and to the risk of false positives, so finding things on scans that are not actually worrisome, but that we now have to investigate and do biopsies, et cetera. So we don't do routine scans on women. We do scans if we're concerned, if there's a symptom or something's going on. So many women will end up getting scans throughout the course of their follow-up treatment, but it's not every 6 months, every year, that sort of thing. And there is some, I get a lot of questions about tumor markers. And again, I'm sort of a younger physician. I'm getting older every day, but since my training, tumor markers have not been approved to use for cancer screening, and that came out in the early 2000s. Prior to that, some of my older colleagues do use tumor markers for screening for recurrence, but what the studies have found, and it's now been disrecommended by all of our national societies to use tumor markers, is that they're unreliable, and that they are both false positive and false negative. So we'll have women who have full, very heavy burden of cancer in their body with normal tumor markers, and then they found that women have high tumor markers, and you look and you can't find any cancer, and you're sending women into a spin of anxiety and testing, and so tumor marker screening is not recommended for early stage breast cancer. We do use tumor markers for metastatic breast cancer in certain situations to help follow disease that's there, for instance in the liver, that we're treating and trying to see if we're getting a response. So I'm just presenting what the data is. People may have physicians who do use tumor markers, and again, they used to be used, and some physicians have not stopped using them, and that's sort of an individual discussion to have with your physician. We also have to look at our patients when we're sitting in the caregiver seat as to what is their family history and had they had any genetic testing to show why they may have developed their cancer or they had an increased risk of developing other cancers. And so as an oncology team, we have to have our radar on for, is this person not only at risk for recurrence of the cancer they've had, but for a new cancer, either a new breast cancer, an ovarian cancer, uterine cancer. I make sure that I check in with my patients, have you had your screening colonoscopy? Has it been that 5 years yet? That's all part of what we're doing, because if we're gonna cure you from your breast cancer, we certainly wanna make sure we don't miss something else that comes up. And finally, we do talk to our patients as much as we can in these 15 to 20-minute visits about lifestyle and diet and exercise and mindfulness and all the things that can help you lead a healthy lifestyle, make you feel good, it's good for your heart, and helps reduce the risk of breast cancer. So I'm going to stop there, and I think we'll be moving on to Michelle, who's going to pick up at that point. Thank you.